We're going to do a Practicode case. This is a one that stumps a lot of people, and we've actually
Alicia,
gone.
before you get started, for those that don't know, can you briefly explain what Practicode is?
Practicode is a company that offers a service with real redacted scenarios or cases or encounters, and so they're multi-specialty, and there's about approximately 100, there's 100 to 150, sometimes more, individual encounters in these specialties. Anything from cardiology to gastroenterology to family practice and fee-for-service, and they do ICD-9, ICD-10. So we offer this as a additional course that students can take where they're wanting real life experience. This isn't necessarily a good thing to go through if you haven't tested for the CPC. This is meant to help you really work on specialties and abstracting of real cases, not scenarios that were created to drive home a guideline. So
Right.
if you think you want to do cardiology or something,
Mhm.
then this is going to help you.
So you get certified, and now you're working hard at getting that first job. This is a perfect thing to do in that gap to get your speed up. And here's an example of one of the cases. And by the way, Alicia conducts a support call every Thursday night when we're not doing this call, and she has all of the MCP, that's our medical coding practicum students, on the first hour, then the coding students the second hour, and our blitz customers the last half hour. So she goes over a lot of these cases, and really the students get a lot out of it. So
ultimately what we do, and I'll show you here, is that we'll do 3 or 4 of these encounters and code them together, and have opinions and look up codes together. We'll put in the numbers and we'll let it score it, and then we'll talk about the rationales, what if we agree or don't agree, what they told us. So actually this again is one that throws people, and basically what it does is everybody's last name is Smith. We don't worry about the dates, but it also gives you excellent experience in looking at how documentation is done across specialties and by different providers. Even though they give all the doctors the same names, you can definitely tell these are set up different. So the first thing is we've got a patient that comes in. Oh, I'm trying to scroll down. Scroll down a little bit and let's look at the first thing we're going to look at is, what's his chief complaint, his chief concern. So now we know he's here for a hospital follow-up, right? And the next thing I like to do is scroll down to the bottom of the document, and this is kind of the auditing and risk adjustment part of me. I always check to make sure there's a good signature. So we've got electronically signed by our doctor with our credential and a date, and a real electronic signature would also have a timestamp on there. So then I want to look and see, well, what does he say is the diagnosis? And that'll just be right above there, and it's usually diagnosis or assessment. And in this assessment, there you go. It says lower extremity swelling secondary to post-CABG. Now, right there, we know this is, he came in for a follow-up, right? But this is the diagnosis that he's given, and this is what he plans to do to treat it, all right? So now that we kind of know what's going on, we're going to go back up to the top, and let's look at the HPI, or the history of the present illness, and find out if that's the only thing going on. Okay, and so our, I'll go up a little bit there. I think it's go to the problem list. This one's set up a little bit different. They listed the problem list first. Now, keep in mind, we know that they're there for a hospital follow-up. So that could be several diagnoses, right? We know what was in the assessment. Now, keep in mind also, lots of things to keep in mind, what type of coding are you doing? If you're doing risk adjustment, it's a whole different set of things you're looking at versus coding this for the office, all right? So a problem list is often copy and pasted, and you don't really want to code off a problem list because it can have things that are outdated, but it shows a continuum of care of what's going on with this patient. So it's important, and we need to look at it. We have more information. We know what type of a cabbage this patient had. We know that the reason was an abnormal EKG. Then the other things, we know he's 5 years status post prostate cancer, he has hyperlipidemia, and he has vertigo, and it's secondary to a specific disorder. Now, we also want to know, what did he come in for? This is being coded for just a regular doctor's office. This isn't risk adjustment or anything else. So we know he came in for a hospital follow-up. Well, why was he in the hospital? Right? And it tells us right there, because he had a cabbage and then there was some problems, okay? And they had an abnormal EKG. Where this trips you up is that we're not concerned about the other problem lists. We're concerned about why he was seen for this encounter. Now, there's things that can be applicable to that, but what is the focus in the diagnosis that we're given? So we look at the allergies, man, not really a big deal. Medication's very, very important. It lets you know what's going on, and sometimes there'll even be dates off to the side. If you don't know what a medication is, you need to go look it up. Even if it's in a problem list, a medication list, and it's not applicable to maybe your diagnosis, but if you see this diphenhydramine, what in the world is diphenhydramine? Go to like drugs.com, Google it. It's Benadryl. But, if you don't know that, you need to know. So if we scroll down a little bit more, this actually, I think, cut the page, and there's some more prescriptions there, but after a while, they're on the other medications that will jump out. We know that they're on potassium. That's the KCI, and they're on potassium because they're on furosemide, which is a water problem. Things like that. So it lets you know what's going on as we scroll down. Now we're going to look at the history, and they're going to tell us what he actually did for the patient. So the patient's here for a follow-up. The EKG was off. He had a bypass. If we looked at the date, this is all kind of like within the same day or something. Then he had no chest wound complications. He presented to the office a week ago, and everything in there as I'm scanning, really says that he has a problem. His legs remain swollen, worse after sitting for 30 minutes, Okay, and it's even getting swollen while he's sitting there. No fevers, no other reason for the cause. So now we're going to look at the physical exam. Now, right now I'm going to focus on diagnosis. I always like doing diagnosis first because I like the diagnosis part of it. So we just do that first. We'll worry about the E&M later. So now this is where you're going to really pull the E&M stuff. The previous stuff is kind of what the patient is telling, the HPI. He's saying, these are my problems. And the doctor will ask questions like, what makes it better? What makes it worse? But these are the questions that the physician is asking and the patient is telling, okay? Then when you get to the physical exam, now this is when the doctor is actually putting their hands on the patient. This is what the doctor observes, not what he's being told, but what he is coming to a conclusion with. So it's two separate parts. This is very, very important. So you want to scan this and look to see if you have anything that jumps out. This is where you'll see a lot of things that either say negative or no, but we know that he has a problem with his extremities, his cardiovascular, that all looks good, except for, isn't that funny that it says, and this is where they get into copy and pasting, and you can tell he messed up on this, because we know his legs were swelling while he was sitting there, right? And it says, no murmur or clicks, and everything. It says femoral, tibial, dorsal, pedis, pulse is intact. You've got swelling. They want to know, is it cutting circulation? No leg swelling. Well, that's a copy and paste, because right above that, it was swelling while he was sitting there talking to them. So anyway, you got to be very careful about what you're reading. And then the skin is also where we're going to see some where this contradicts it. See, it says he has, let's see, an incision. Both legs are significantly, and then scroll down. And I think that says, we'll say swollen. Swollen, +3. Okay, no weeping noted, and now we're talking about the integrity of the skin and stuff like that. Okay, now the assessment, we know lower extremity swelling secondary to him having that cabbage. And the plan. Now let's go look at the answers that were given. On the next page. This is both, the top is, these are the answers that Practicode gave us. And then these are the answers, and I just drew these random for us from a student, but these are very common that get coded. One, they say it's edema, but nowhere in the document did they say, the physician state that the patient had edema. He constantly stated that they had swelling of the limbs, swelling. And that is actually, you can see, 2 different diagnoses. Then he's status post a cabbage, and there's a V code for that. That's very pertinent to his care. Now, this is where you get into some funny things where it's not always black and white. Now, so it's not edema, it's leg swelling. Now, it may change and become edema later, but he didn't say edema, and we can only code what he states. He has hyperlipidemia, but that wasn't in the assessment. Is it pertinent to his care for what's going on? Yeah, probably, but it's not in his assessment, so that's why they didn't code it. And the history of the prostate malignancy, is that pertinent to his bypass and what the follow-up is all about, what's going on? Now, not really. If you could make a case that it's part of the plan of care, but he didn't address that. Otherwise, that was a problem list, and so we can't really code off a problem list. We already saw in this document how copy and paste will get you in trouble. He said right there that there was no leg swelling, and then he turned around and said that there was leg swelling. So you have to be very careful. If you're ever in doubt about this, what you do is you go query the physician. You ask him and say, you said this was limb swelling. Is this edema? And if he says, no, it's not edema. Okay, thank you very much for clarifying that. And then, is his hyperlipidemia in any way pertinent to this? No, it isn't. Is the fact that he, is status post prostate, could that have anything to do with the swelling? And if he says yes, well, then it's pertinent. Then you say, okay, then, you're coding that. And then, of course, you have your leveling, your E&M. That's really, in some part, the easiest part. They did several tests. He did exams. You can click off all of the little parts of doing the exam for an outpatient, and that it's not a new it's an established patient, and it got a 99214. But for the most part, it was going to be a 99214. But that right there is a little overview. That's kind of how we do it. If we have questions about certain things, like what's the medication for hyperlipidemia, we go look it up while we're doing this. And we spend, like an hour doing 3 or 4 cases. Sometimes we may only get through 2 because we break it down, understand the disease process. We do the E&M leveling together, and, and we kind of joke about, so-and-so said it was a 214, and we picked a 213, and so it allows several people with several backgrounds and levels of experience to work together as a team and see how other people think. So unlike these Q&A webinars, it's interactive, and we actually talk to each other, you can get a lot of insight from from the students and their backgrounds and their experiences, and so that's a lot of fun. I often learn
how to tease it out, get that information out.
Exactly.
Do you need more medical certification training? Go to www.cco.us. And don't forget to subscribe to our YouTube channel for updates.